We're really pleased tonight to have Dr. Abida Solomon from Prairie View A&M University College of Nursing as our moderator. She has a degree in epidemiology from the UT School of Public Health. Dr. Solomon, please.
Thank you. Thank you, Dr. Linda, for the introduction. Let me leave this water here before I spill. Okay. Thank you, and welcome to everybody. Welcome to today's discussion on safety net programs. I am looking forward to a vibrant, interactive discussion on this topic today. So please do not hesitate to ask questions and also make contributions as we proceed with the discussion. And just a reminder, this is a 90-minute discussion session. It's a long time to be sitting. So I'm just reminding you to do your sitting exercises because we don't want no blood clots in the end. Okay, so I have up here with me a distinguished group of professionals who have worked in healthcare, and they come with varied backgrounds and experiences, and they're gonna help us with today's discussion. With that said, I'm gonna ask each one of them to introduce themselves and share with us a little bit about their background. So we will start with Ms. Love, Ms. Karen Love.
We'll do personal first, right?
Yes,
okay.
ma'am.
So my name is Karen Love. I am currently the Executive Vice President and Chief Operating Officer for Community Health Choice, which is a local managed Medicaid HMO. I have spent most of my career on the provider side of the fence, working with hospitals, large physician groups, management services organizations that provide services to physician groups. But about a little over 5 years ago, I crossed over to the dark side, which is how we used to refer to the payers when I worked for the providers, and have had an amazing experience at Community Health Choice since. I think in the healthcare setting, we generally have the opportunity to impact the health of one individual patient at a time, whereas in my role at Community Health Choice, I have the opportunity to impact the health of populations, and that is truly exciting. And so I am delighted to be with you tonight.
Thank you. Dr. Ebeid?
Yes, my name is Adlia Ebeid, and I am the pharmacy director at San Jose Clinic here in Midtown Houston. My background is mainly in academia and medication management. About 9 years ago or so, I actually came to San Jose Clinic as a volunteer because it is a volunteer-run operation, and we started their first disease state management program that played as liaison between the medical providers and the pharmacy department. And then it just grew from there, and then I decided to come on board as pharmacy director to try to enhance that even more and make a true impact on this patient population. Kind of as that you mentioned, it's very unique to be able to make an impact on an entire patient population, but yeah, definitely one patient at a time. And so through our charity work at San Jose Clinic and then managing our volunteer contributions, I've been there for about 3 years.
Thank you.
My name is Sandra Russell. I'm a family nurse practitioner. I have been working with the Healthcare for the Homeless program with Harris Health Systems for the past 14 years. We provide healthcare to the indigent population, and we take care of chronic illnesses, acute illnesses, and we try to get our patients motivated to take care of themselves, empower themselves, even though they are in a homeless state. It is one of the most rewarding jobs I've ever had because there's a lot of autonomy as far as being a nurse practitioner, but also the quality of work and the quality of care that we provide to the patients so they can keep coming back and take care of their own health. And because with homelessness, health care is lower on the totem pole than your basic needs. So to teach the patients on how to take care of themselves, and that's an important aspect of their life as well.
Thank you.
My name is Nageeb Abdalla. I'm Associate Medical Director of the Homeless Program, Harris County Homeless Program, in the city of Houston. And I have been from Egypt to France to America. And I take my profession as a call, and I work with the homeless, and I feel this is rewarding to me. Also, at the end of the day, I go home very happy, helping this group of population in the Harris County.
Thank you, Dr. Abdalla.
Hi, my name is Shannon Hart. I am an RN by background, and I'm the Director of Operations at El Centro de Corazon. I think that my background gives me a great advantage to be able to really make changes and impact what we do on a day-to-day basis. Before I joined El Centro, I was a Director of Nursing for a home health agency. So I was able to really get a hands-on experience of what everyone's life looks like in their home. What are their real situations? Lack of money for prescriptions, lack of food. Why do they have the bed sore? Well, their bed is positioned the wrong way. So being able to take that experience and then bring it into the clinic setting to be able to work with the providers to look at all the other things that are factors in not just that one prescription we're handing out, what else is affecting their day-to-day well-being. So it's been really exciting at El Centro the past 7 years. We've been able to develop a lot of new programs and continue to increase the patients that we touch. Thanks.
And my name is Kevin Nix. I'm the Senior Director of Communications and Public Affairs at Legacy Community Health here in Houston. We have more than 30 clinics in the region. Been here for in Montrose at least, for 40 years. Have grown immensely from a little clinic in the 80s that focused on HIV and AIDS to now a full federally qualified health center, providing the gamut, OB-GYN, behavioral health, pediatrics, adult primary, across the board, and all kinds of social services today. My background, actually, I've only been at Legacy and in healthcare this way for just 2 years. My background was in DC in public policy and legislative work, in politics and media up there, so in DC, and I'm glad to be back home in Texas. I'm from here, and there sure is a lot of work to do, though, here in Houston for the patient population we all see, but we see also uninsured and insured patients, but on the low income range of things.
Thank you all for those wonderful introductions. Before I proceed with the discussion, I'd like to make a few remarks. This is the reality that we live with, that healthcare access disparity between the insured and uninsured is a significant national issue. It's very difficult, and I'm sure most of you can identify with that. I have used these services as a student, a graduate student in Austin. So it's very difficult to access care when you are uninsured and you are poor. And the number of the uninsured, it's estimated to be about 28 million right now, which is somehow good news because that's a decrease from the 44 million that was reported in 2013, thanks to the ACA and the Medicaid Expansion provision. So you would see variation in the number of uninsured based on where you go. Some states assumed the collective social responsibility and expanded their programs. And so in those states, you would see the number of uninsured have decreased. But in states that didn't participate, you would find out they still have high number of uninsured. Texas is an example. We have about 4.3 million uninsured Texans. And for the Houston, Galveston metro area, we have about 1.6 million people that are uninsured. So this is a big issue. How did safety net program start? Is this safety net programs has become the default system in terms of provision of care services to the uninsured, the poor, and other vulnerable populations. So as the discussion progresses today, you would see that we have different types of providers, such as the center, community health centers. We also have the rural health centers, the federally qualified health centers, and retail clinic, and other providers. This is just a loose kind of organized, both public and private healthcare programs that have stepped up to the plate in the provision of these services for this special population. And in terms of funding, some of these providers do not get funding, some do get funding. And so we would hear from the providers those programs that have funding from the Public Health Service Act. Some of them get funding from under Section 330 of that act. Some get enhanced reimbursement from Medicare and Medicaid. And also, some just depend on what? Charitable donations. So we'll get to see where some of this funding comes from the panel. With that said, I would like the panel to look at the next first question, which we are trying to understand what are the key features of safety net programs. And if you don't mind, it doesn't have to be in any order. Anybody can chime in. And it's also to the audience, don't hesitate to chime in with your comments and contributions. So we would be, we ready? With anybody wants to take it up? Ms. Love?
I'll go ahead and start. Since I'm the only representative of a payer organization, I think you guys are all represent providers. So Community Health Choice is, as I mentioned, a Medicaid managed care organization. We were founded 20 years ago by the Harris County Hospital District. Around that time, many state governments were deciding that the traditional fee-for-service Medicaid program wasn't working and costs were spiraling out of control. And so they wanted to move to a managed care model. Harris County Hospital District recognized that. Harris County was one of the first areas that Texas brought managed Medicaid to. So we have a 20-year history of servicing the Medicaid population. There are actually multiple Medicaid programs in Texas. So there are, the STAR program is the program for pregnant women and children primarily. There is the STAR Health program, which is the program for foster children, children under the state's care. There is STAR Kids, which is a brand new Medicaid program started last year, which is the program for children with disabilities Medicaid program. And then there is the STAR Plus program, which is the Medicaid program for the age, blind, and disabled. Currently, Community Health Choice is in the STAR program, Pregnant Women and Kids. We also serve the CHIP, Children's Health Insurance Program members. So we receive federal and state funding to pay for services delivered by these providers and many others. Medicaid is a joint federal-state program, so every state has a match rate. So the state puts up 40%, the federal government puts up 60%. That creates the money to fund the services. So the money funnels through us. We get a capitation payment for all of the members who enroll with us every month, and we are to deliver all of the services that they are entitled to for that monthly amount. Obviously, pregnant women, we get a higher monthly premium because they're only with us for 9 months and pretty sure they're going to have a hospitalization, right? So we get a higher premium for them. Kids, by and large, are healthy, so the premiums for kids are relatively lower. We serve about 280,000 Medicaid, STAR, and CHIP members currently, so that's mostly pregnant women and kids. The state is actually in a procurement process for the STAR Plus program, which is the age, blind, and disabled, and I have just spent 2 days of 12 straight hours reading our final response that's due next week. So I'm up to here with Star Plus, but it is a population we have not served up to this point, but we are very much looking forward to serve. So I'll stop there, and I'm sure we'll talk more about it.
Yes, Mr. Nix.
I mean, I can speak to I can barely see that, the target population. So we see, at least at Legacy, it's really representative of Houston, Houston's diversity. And about 60% of our patients are Hispanic, and then below that are African American, and then we go from there. So the bulk, though, of our patients, in both insured and uninsured, are in those two demographic groups. In terms of the funding, I mean, I agree with all of the ways that the federal and state funding. I mean, essentially government grants fund us. Less so now than when we started. Heavy philanthropy work from private donors and foundations. Then also, you know, the fee-for-service and the wraparound rates and the reimbursement from Medicaid are all sort of go into the pot. It's a very, I don't want to know, I still don't want to know how it works, to be honest with you, because it's so complicated. But, you know, healthcare financing is complicated, and so we are at sort of a mash pit of all kinds of different ways we're paid. For the most part, and on the, you know, key features, I would say we have to see anybody that walks through our doors, regardless of the ability to pay, and like period. That's the mandate, and we do that. And from a branding perspective, I think we've done a pretty good job over the past 4 decades of having that sort of welcoming brand, believing in diversity, inclusion. Everybody comes in here. You're not discriminated against and all of that. Obviously, we have clinics in the 5th Ward and in Southwest Houston that are heavy on the maternity side, and so we're seeing more and more pregnant women and then their kids once they're born. We don't do deliveries, but then once they get back from the hospital, they come back with their kids and do pediatrics, and now we just started a geriatric service line, so from beginning to end.
Immunizations.
Yes.
You see refugee too.
What?
Refugee clinic too. Refugee patient. Refugee.
Refugees?
Do we see them? Honestly, I don't know because we don't ask.
Oh, okay.
And we have to see everybody. Everybody that walks through the door.
Okay.
Right.
In our program, our health program, Harris County Homeless Health Program, there is in the Harris County 2 homeless program, Baylor HHH program and Harris County homeless program. The oldest is a Harris County homeless program. This year is 30 years. The program is in function, and we get grant from the federal government, HRSA, and we serve everybody who comes and claim that he is or she is homeless, and we see from kids to adult. We work in shelters, homeless shelters, about 10 homeless shelters. We have small clinic run by nurse practitioner. Sarama is one of our nurse practitioners for the past, 10 years almost?
14.
14 years, okay, 14 years. I have been with the program for 15 years. We also do have a mobile unit that goes to everywhere, almost 20 locations, where is homeless population congregate and go and serve them over there. We have a dental unit. We have social services too, enable them. We have eligibility. They have to go to eligibility to make sure that they are homeless. And we really, last year, we have a number for 2016. We serve about 10,000 unduplicated customer with about 29,000 visit, everything including. We do vaccination, we do medication, and we are part of the Harris Health system, so we send our patient to Bentab, LBJ, or other clinic, and also use their services. We are part of the Harris Health system.
Do you do mammograms?
We do mammogram. Yes, we do mammograms. We do everything, yes, like any other clinic in the nation.
Do you know what kind of specialists do you have?
We have, in the homeless program, we have family doctors, like me, and we have psychiatrists, we have dentists, and we have behavioral therapists. But if we need any other specialty, since we are part of the Harris Health system, we refer our patient to the specialist in this, and we have the same, our patient receives the same service as anybody else in the Harris Health system.
Is the Baylor part one that works for search?
I am Baylor faculty, but Baylor decided a long time ago, the clinic, the Harris Health System clinics, they have 3 hospitals and 19 clinics and 6 same-day clinic and other centers. So they decided 50 years ago that half of their clinic and hospital run by Baylor faculty and half run by UT faculty. It happens that I am Baylor faculty. So I'm borrowed from Baylor to serve in the health homeless program. So I have 2 hats.
To add to what Dr. Abdalla said, he didn't say that he runs a procedure clinic for us. So when we have patients that need ingrown toenail removal or IND of any kind, we send our patients to the procedure clinic, and it's done within our program. And also, what makes our program a wonderful program, I think, is that that we have access to LBJ, Bentab. Our patients have access once they qualify for the Gold Card. They have access to Harvoni, for example, the Hep C medication. We send them to the GI clinic. So all the different clinics, neuro, any head to toe problem the patients may have, we can send them and fix them. And so it's a very much a collaborative effort, and to work for the patient.
What's your compliance like from the homeless population? Are they able to follow through? Like Harmony, if you're taking Harmony, you've got to, it's not just one.
With the Harvoni, they go to the GI clinic, and once they get started on that, I've seen most of my patients complete that. Now, unless, there may be, extra circumstances that they may not. But once they start on that treatment, they're pretty good. But as far as keeping regular appointments, to specialty clinics or maybe to a mammogram or something like that, they may or may, just...
I mean, healthcare is not the priority for some of the homeless. So we're trying to really educate them that health also is important for their life. I remember when we started the open access clinic on Lord of Street at Fannin, we don't have an appointment, so people come from the street directly to the clinic, and they come in the morning, 8 o'clock in the morning, 15 patients wanted to see the doctor. They wait. The time I see half of them, the rest is gone, because they can't wait really 5 hours, 6 hours to see the doctor. This is a homeless population. Guess what? Nowadays, after 10 years, open access clinic, Lord of Street, they come at 8 o'clock in the morning, they stay until seen by the doctor. Sometimes they stay 6 to 7 hours waiting. Honestly, we are really impressed how some of them, they now know that health, blood pressure, important, diabetes is important, this kind of stuff is important, so they wait. So that's improvement really for this particular population.
Because if they see the same provider over and over, you have established a rapport with them, and they will come back.
So can I pick up on, you mentioned the Gold Card program. So yes. This is an important thing in Texas. So Texas has a state law that requires every county to make provisions for indigent care. The law has been there for, I don't know, early 70s, I think maybe. And what it identifies in the law is what was meant to be the floor. So it currently says 20 people can't make more than, well, again, the floor was supposed to be 25% of poverty, right? And no more than $30,000, that's the budget, in a calendar year for an individual. So that was meant to be the floor. Counties could be more generous, but they couldn't escape the obligation below that point. And since it's up to every county, we have 254 counties in Texas, so it's pretty varied. But a large number of the suburban counties have adopted that floor. So for example, in Harris County created a hospital district, actually runs facilities to meet its indigent care obligation, and they have set their indigent threshold at 150% of poverty. So they are a more generous, Harris County is a more generous county. You go to Fort Bend, you go to Brazoria, you go to some of the counties around us, and they're sitting there with that floor, have very restrictive programs, and so if you are in Fort Bend and you are indigent, your best bet is to move into Harris County so you can qualify for services. They used to refer to the Harris Health program as the Gold Card, and people used to, it used to be a Gold Card, and that's why they called it that. But it got confusing for some people because it is not it's not an insurance card. So you may have an Aetna or a Blue Cross or a Community Health Choice card. I know at least one person in the audience has a Community Health Choice card in their wallet. And that means you can go to any provider in that network, right, for that carrier. At Harris Health, once you qualify for their financial assistance program, you are entitled to discounts if you receive services at Harris Health. But you cannot take that financial assistance card and go anywhere else and get services without paying, self-pay. So.
Yeah, I want to share with you guys too about San Jose Clinic and how I've been hearing, about reimbursements and billing, and just a little bit of what's different about San Jose Clinic that kind of captures the gap in what all these great people are providing at their clinics. And so our patient population is less than 250% of the federal poverty level. So anybody who makes less than 250% qualifies for care at San Jose Clinic without zip code restriction. So we have patients from Austin and El Paso and all over. And what's really unique to that is also we are very much like Legacy. We mimic the patient population we have in Houston, and that we're very diverse, but we also accept undocumented patients, or we don't ask. And for that reason, we see a lot of really complex disease states. And from the pharmacy, we have patients that are on 10 chronic medications, and that's normal. That's a regular thing for them. And I know some people are shaking their heads, and for some, that's jaw-dropping. I know when I told my COO, she's like, 10? I was like, this is kind of normal when people haven't been making their healthcare a priority. San Jose, billing-wise, we don't charge. We are a ministry of the Archdiocese of Galveston, Houston, and we receive a lot of our funding through in-kind donations and through the Catholic organization, and then through some philanthropic. We don't have operational federal grants, unfortunately, and we don't really charge our patients. They do contribute to their care because we feel like if they contribute, then they feel like they're actually a part of their care. And when it becomes free services, they might not take it as seriously. So we do ask for a small fee, but if they can't pay it, we waive that. It's not a problem at all. But our operational expenses run around mainly in-kind donations and some of the big events that we do throughout the year to collect those funds. Fortunately and unfortunately, we don't bill because, trust me, I don't love the hassle being in the pharmacy and dealing with prior authorizations and bin numbers and group numbers. I'm grateful for that. But on the flip side of it, it makes it really hard to keep our doors open because we are very much like our patient population. We're living month to month, making sure that we meet our operational expenses. And that is what's very unique. We kind of feel our patients. And in fact, some of the employees there are our patients as well because they fall into this category where they just don't make enough money to support themselves and their health care or their family members. and they don't qualify for Medicaid or for the Harris Health Program because they don't live in the county. So that's kind of a unique thing for me to hear everybody talking here, that everybody kind of put together tries to cover that entire spectrum, that entire needy population, and everybody's kind of funded in a different way.
Did I see it? Yeah, go ahead, sir.
I thank you for everybody for coming tonight. The question I had, actually, Karen had mentioned about dollars you got from the federal side. I think it's important also to understand, like, what are some other funds that we get from the federal side, maybe from the FQHCs as well. But what also is important is, what do we not get where we have the opportunity? Where are we leaving money on the table that we could be taking from from the federal government that we're not taking the opportunity of?
Well, Medicaid expansion is one.
It's huge.
And Texas is.
So hopefully everybody understands, the Affordable Care Act really had two parts to it. One was Medicaid expansion, to essentially cover people between 0 and 133, 138%, depending on whether you count the 5% asset test. And then for those people between 100% and 400% of poverty, there were the health insurance marketplaces. I neglected to mention earlier, we are in the health insurance marketplace. I sell Obamacare, and we have about 115,000 members in our health plan currently under the Affordable Care Act plans. The problem being, as you mentioned, when Texas didn't do the Medicaid expansion, that left those people below 100%, because the marketplace starts at 100% and goes to 400%. People who are under 100%, who are not pregnant women, kids, or disabled individuals, essentially get no financial assistance whatsoever. So we have left huge dollars on the table by not doing the Medicaid expansion.
I'd also add, well, another federal program is Ryan White funding, comes through the state to Legacy and maybe others, but that's a nice chunk. But then also, I think that generally the safety net is sort of under threat in the U.S., right? And so the community health center funding that we always get regularly barely just passed, and that's $6 billion. So we do need, Legacy and others I know, need that money. I'm concerned that it was so hard to pass it last time, which is usually through Congress, it's usually a bipartisan issue. It's going to be even more difficult as we go forward. Same with CHIP. So I see the federal funding, declining.
Yeah, I just wanted to try to summarize the funding portion of it, because we've talked a lot about it. But the way that I think about the funding for safety net programs is there's probably about 25 large sources of funding for people, depending on who they are, what provider they're seeing, and which particular body function is involved. So that, one of the real terrible problems in safety net care is the fragmentation that says the biggest funder of this care is actually the federal government through Medicaid, but they also have separate Ryan White grants, and there's separate funding for uncompensated care, which doesn't go through the Medicaid program but goes directly to hospitals, and several, a number of other federal programs. Then there's state funds, some of which is Medicaid, but some of which is separate funding for breast cancer, separate funding for mental health services, separate funding for the Texas Women's Health Program, a whole series of those kind of programs. Then you have the county funds, which would probably be the next largest, which is the county property taxes that Karen talked about, that go to indigent care people who are not eligible for Medicaid or Medicare or subsidies under the Affordable Care Act. And then you have city funds that are going on, and county funds that don't go to the hospital district, that go like to the jail, where a lot of indigent care is provided. Then you have the care that is provided by the nonprofit hospital systems that provide either community grants or just uncompensated care in their emergency rooms, which is an indirect tax on everybody that does have insurance. Then there's philanthropy that support, whether or not be the churches or big foundations. And then, you have actual contributions by people actually paying this themselves. And so it is a gigantic fragmented mess, which I've been trying for 10 years to be able to put all the pieces together. And so I think one of the biggest issues that all of these guys face, and I've talked to all the folks at the FQHCs, for example, every FQHC in town probably has 25 different potential sources of funds for you as a patient, depending on who you are, what's wrong with you right now, what's going on in your life, and it's just awful. I can't believe the FQHCs do what they do, trying to figure out where are all the different sources of funding for the programs.
Not too efficient.
It's not very efficient from a funding standpoint. Some of us have ideas how we could make it more efficient, but not doing very well in Austin or Washington with that.
It would require policymakers willing to listen, right?
I would just add to Ken's comment, that nice summary, that the ACA was moving us in a direction, to some extent, rationalizing that by setting an eligibility level for all Medicaid, no matter whether you're on Medicaid because of your disability or because you're pregnant or because you're a low-income parent or because you're a kid, at 138% of FPL, across the board, no matter what. And everybody would be qualified. So like the homeless population, which my understanding is includes a lot of childless adult people who are low income, don't qualify at all for Medicaid because they don't have kids, and unless they can get on as a disabled person because of a mental illness or physical disability. So that we were moving in that direction. Well, we never did in Texas, but the rest of the country was moving in that direction. Now we have within these different payers, if I could add to the complexity, Ken, I can't believe that I'm saying this. Now that we're moving away from, some of us are moving away, payers are moving away from fee-for-service to all kinds of alternative payment models for the populations that we cover. We're adding another complexity for you guys, you healthcare providers up there in the safety net. Because these 25 providers, in the past, they all basically paid you the same, a fee for service. But going forward, some of them are starting to want to capitate you. Some are wanting to start to pay you on some kind of value-based payment incentive program or global payment program. So I just wonder, are you guys, or am I? Is this actually happening to you guys at the FQHC and Harris Health Clinic level? That you are, some of the payers are coming to you and asking you to participate in an alternative payment model type program?
So I'll just repeat what my CEO, Katie Cole, has said, and that is we are going to we're moving toward the value-based model, no question about it. Not worried about that. It's what happens in between and how you get there. Yeah. For all of the reasons you just laid out. But yes, this is where we're going with everybody else.
Yep. So you're challenged as an organization to respond because there are data collection issues, data sharing issues, counting of this or that you didn't count before in terms of an outcome for a patient that the payer wants you to count. Lots of challenges.
And it, in my terms, it's just a bunch of bureaucracy, which is awful. But you got to do it, right?
Actually, I have to compliment Legacy. They've actually approached us. We've been running a maternity bundled payment pilot program with UTMB and UT physicians here in Houston for the past couple of years. And Dr. Barnes, your medical director, and your CEO, Katie, met with us, I think it was right before Christmas, and said, we know we need to go there. We need to get some experience, and we'd rather get some experience with you guys because we know you guys and you're local and you're committed to the safety net, so you'll help us figure this out. And so we're in the beginning phases of looking at how to bring them into that program.
And I think for us, knowing it's coming and just trying to do the groundwork to get us ready for that point. The data collection and everything will come, it has to, but trying to ensure that we have programs that support that new model of care. Our highest concentration of population for El Centro is women of childbearing age and from 0 to 1 years old. So one of the things that we've done to try to just even improve the quality of care that we're delivering for that specific population is we joined with Centering Healthcare Institute, and we've changed our prenatal and pediatric well child care to support that, which we're seeing actually really great outcomes just in our first year. Our preterm birth weight rate is lower than our general population. Immunizations are higher as well. We're also tracking a postpartum compliance rate and contraceptive choice. So we're hoping that those programs will ensure us once we do get to that different payment that they're asking us.
Thank you.
Utilizing the chronic care, management approach, because that seems to be a very big push, and that actually is a lot of your patients, your clients fall in that realm. So that might be a very exciting payment model, to utilize those codes.
Thank you.
One more question of the panel. I was reading somewhere, and I don't remember where it was, but I was reading somewhere that we're trying to document everybody who's in Medicaid so that when they go to one place to get help, that it's, we're trying to prevent duplication of services. Is that correct? Is there a database now that?
There is, and actually Nick Bonvino is in the back of the room. I happen to know something about this because I actually wrote their very first grant, but Greater Houston Health Connect is the local health information exchange, which we are encouraging all of our network providers to sign up with so that those kinds of records can be exchanged electronically, securely, privately, with consent, all of those good things, so that we can do that very thing. I think particularly when you're talking about the uninsured population, when there isn't enough money to serve that population to begin with, and this is my personal opinion, you said we were representing ourselves, right?
Yeah,
so it's criminal not to participate in a way that allows you to be sure that you are using those dollars, your limited indigent care, dollars, as efficiently as you possibly can.
To serve more people?
Correct.
Thank you, Karen. We appreciate Community Health Choice support. But yes, Greater Houston Health Connect is the regional HIE. We are a not-for-profit as well, committed to delivering quality care across the community. And we do that by connecting all providers. I would say for the FQHCs, we have the majority connected and would hope we can get the remainder as well. But quite simply, it's assisting providers to assess the patient by collecting all the information across the community from all the different encounters, which would lead into rendering a better diagnosis, care planning, e-prescribing, all of the things that will help you as providers deliver quality care to your patients, ensure their patient safety, and do it in a more efficient way, eliminating redundant tests and other things that can go wrong when you don't know everything about the patient. So we're here to assist in this specific segment as well as all citizens in the community. Thank you.
Thank you.
It's very, I think it's very important to have this communication between health systems, but also we need to understand, as I talked about my population that I work with, the homeless person who goes to St. Joseph or Memorial, and they do CAT scan, MRI, and then they, after 8 hours or 15 hours waiting, they finish by giving him a prescription. What this guy gonna do? They come to me 2 days later. I have to repeat everything to make sure that the diagnosis is correct before I give him the medication. So it's useless effort, fragmented, useless, more expensive than any other country in the whole world. I used to live in France for 5 years. Its system, health system is simple. One provider for one person, and you go and you get your stuff done. Here, almost every week, I receive one or two of my homeless patients. They just decided to go to the emergency room, this particular emergency room, and come to me with 5, 6 prescriptions.
And unfortunately, these are the dollars that you were talking
Yeah.
about that end up kind of becoming our responsibility as taxpayers. And so if we can focus on that preventive care and that education prior to, and do like the chronic management like you're talking about, prior to these ER visits and hospitalizations, that's really where it's at, is beefing up our primary care system and preventive care system.
We can, but it's complicated.
We
It's not
can't-
easy.
We can't get it right then. But we do have a link. I know the homeless programs have linked through electronic medical records. And so if they go to any of the linked providers, I can see what they've done. So if they've just done labs last week, I don't have to repeat that again because it's in the system. I have access to it versus getting consent forms, sending it to, faxing it this way and that way. And so we end up, duplicating services sometimes because we don't have immediate access to that information.
And for us, we have Epic, which is the same system as, same system as Harris Health. And for our OB patients, our providers become very frustrated whenever they can see the OB ultrasound report. However, they don't trust it. They want to see the ultrasound images. And so that report becomes almost just worthless at that point.
Dr. Becker. Yes.
Just to try to get clear where we are with this, though, this community-wide health information sharing through the exchange, health information, through the Health Connect, and it's wonderful that there are some clinicians that are able to use this and look up and see where some of their patients have been receiving in terms of care and their condition with other providers. But my understanding is that it's very limited for those of us who are trying to compete in this brave new world of alternative payment models and value-based payment, where we're being asked to be responsible for a population of patients that we're serving, like all of our adults with diabetes, okay, or all of our kids' well-child visit rates, all right? And there is that information where we want to go to the Health Connect and get for a population of people what their rates of diabetes are, or what their screening rates of mammography for cancer are, is not something that a healthcare manager or a healthcare payer can get now across patients. Am I correct in that?
Okay, so Health Connect's been going. Karen was instrumental in the founding of the entity, and to bring all of these providers together that compete rigorously amongst themselves, contentious relationships with the payers in the community. It was very difficult to do that. Now, this is 7 years later. We've got just about all of the hospital systems contract. In fact, we maybe this week do have all the hospital systems connected. Yes. Anybody from Memorial here? Yeah. That occurred actually the day before Thanksgiving. It was a memorable day in my life. I could tell you that for certain. And HCA has approved an agreement, and we're waiting to get that executed. So the information is there amongst providers, but one of the policies that we had to enact early on was that while we're providing a service to those that are at risk, and Karen can testify as well, that's notifications of this population that you're at risk for when they present or at any one of the healthcare systems or discharge. The ADT transaction is what comes to us, and we match that against the patient population that you're at risk for, and we'll send you a real-time notification. So if you are taking risk with the population, obviously the first thing you'd want to do is be aware and notified of what's going on. And then secondarily, then be able to access their clinical history in a view. Now, that's something that our board has not yet approved, but I think we're getting close to that. And I say that because as more providers are taking this risk through MSSP programs or other risk-based agreements, they obviously already can do that lookup. So ideally, if you've got a population that's at risk, notification comes to you from us that they've just presented in an ED. You can then go on and view a consolidated look at their histories to then say, all right, well, how do we best manage this situation, both where they are currently and then over time. So we're getting there. We, like most of everybody up there, we're a young company still, but maturing, needing more funding to be able to do what we need. There's no money, no mission as well. But that is an area that is something that I think we can assist with, again, in managing these high-risk populations.
Thank you. Okay. So let's assume that by a miracle, we get some universal health insurance or coverage. Do you think your patients will still, now that they will have choice, will they still come to your facilities or come to you as providers?
So I can speak on behalf of San Jose Clinic. We've actually had instances currently where our patients become Medicare eligible and they turn of age. And interesting to see how they'll try to deviate away from their birth date to make sure and make us realize that, no, I really like this doctor. I want to stay at the clinic. They told me I have to apply maybe 9 months, just making up random things after I turn 65. And we want to encourage them to seek that option that they have because it opens up so many doors for them. We're here to cater to a specific patient population, and we want to kind of give them that nudge out the door because we know it's better for them, ultimately for the long term. And while we try to provide as much care for them in the interim, for a permanent option for them to have like their whole health care, we know that one of these entities will be best. But
and if they don't use that option, then they are using dollars that you should be using for indigent care people, right?
Exactly.
So really, they should move on to
right, exactly. And so we do
providers.
see it very often that they're not ready to go. And we also see it to where, because we cater to a lot of the parents who have kids who qualify for Medicaid and CHIP, we also see them trying to bring their children, especially when there was some political unrest regarding their status, in fear of being identified. And so they're like, we'll just bring our kids here too. And we're like, well, really, your children should have a healthcare home that is more consistent with pediatric services that Medicaid and CHIP is so willingly offering. And so it's very difficult to educate them on that level, but it's also very rewarding once they get into that process and they're able to identify their care and get healthier in that aspect. So we're happy to turn them over to you guys, but they are very reluctant to leave. So I definitely think, to answer to your question, that they would stay. We try to establish a very comfortable environment at San Jose Clinic. We're very welcoming, very diverse. In fact, last year we had about 4,700 unique patients that translated into 32,000 visits, medical, dental, specialty, and pharmacy. And to speak to your point, with our resources, for example, in the pharmacy, thanks to Harvey, we brought in about $8 million worth of donated medications and insulins and vaccines that we're able to utilize for this community. But if we had to share that with the entire city, there's no way we would have been able to cover the depth of health that we were able to because of our patient population cohort.
Yeah. Anybody from the audience, have you used? Yes, ma'am.
So, given that the patient finds value in an organization that does deal with diversity and does deal with, solutions that they can access easily, doesn't that reflect on the other organizations if they don't want to go to those other places, is that your model is working and can we learn from your model? So anyway, that's just my
Short
point
answer.
from that,
Short answer.
from a customer standpoint and a value proposition, because those patients aren't finding that else place. And so it may be revealing an opportunity there. So anyway, just a comment.
Yeah, no, I do want to speak on that because when I first started with San Jose Clinic, I came on as a volunteer, and I was through an academic affiliation. First thing I asked, why isn't there one of these on every corner? Like, we really should just pop these up everywhere. Because there's definitely a need, and clearly patients want to come. We have the numbers to show it, and they want to stay. Unfortunately, because like I mentioned about our operational expenses, it's a very unique model, and we're not relying on any reimbursements from any heavy, donors like the government.
My point is, can't you teach the other healthcare?
Well, so I was going to speak to that. Ironically enough, the other healthcare providers are at our clinic. They're the ones providing the services. So our physicians are all volunteer with the exception of one that comes from Baylor, and we have one nurse practitioner. So all of our physicians are volunteer. I have 13 pharmacy volunteers, believe it or not, who actually volunteer in the pharmacy as well. And so these are people that have their own practices or have had their practices and are now retired, or used to be, like, for example, ER physicians and now just want to kind of keep up with the patient population and have interaction and do general medicine. So these are people that are either in the medical center here or they have their own practices. And unfortunately, I don't know if it's the providers that have the say as opposed to the bureaucracy and the upper administrations and the operations that kind of govern those details. I think every provider, if you ask them, they want to come to work. They want to spend an hour talking to each patient. They want to learn about their family and learn about their disease states, but it's not always the most cost-effective model. And unfortunately, I don't think it's the providers that get that final say. I don't know if you guys want to kind of chime into that.
I would say, I'll just speak from my perspective where I work. I think as more people have gotten insurance under the ACA, our patients' levels have gone up. So again, it's not extreme poverty only. It's also, there's a ton of other very low-income folks who, and also in the coverage gap that fall in there, who, and then some do have insurance on the marketplace and all the other things we talked about. To the other question up there is, I think we haven't talked about what community really means yet, and I think it's both inside the exam room and all of this payment stuff and the financial stuff we're talking about, but there's a heavy outside the exam room component to this whole thing that Memorial Hermann, no offense, at all, any big hospital. I didn't mean to name one. Now I'm gonna get in trouble. But no, shoot. But anyway, but there is a big difference between a community health center and system and a big hospital system, right? And so we are, to the question up there about why do patients even choose to go to safety net providers, I think there is the welcoming aspect, the personalized attention aspect, but also there's transportation, there's geographic issues in this city. As a FQHC, you have to be located in a medically underserved area. That's why we're in Fifth Ward, that's why we're in Southwest Houston, that's why we're building a brand new facility that opens next month in North Side. And same with Beaumont and Baytown and Deer Park. So there are still the fundamentals about why at least an FQHC were created exist then, now, and in the future, regardless of the insurance question.
And I think the model really works, having to be able to provide pediatric care along with for a parent that their child needs psychological testing, that needs to be seen by the psychiatrist, to have those providers all in one building and talking with one another and doing true case management for that child is something that I think is extremely difficult for a private pediatrician to provide. So I think that's really a unique aspect that we're able to deliver as FQHCs.
Okay, go ahead.
Yeah, to speak to all of these points, especially what Mr. Nix was saying, I agree. Like, I feel like a provider at San Jose versus a Medicare provider would provide roughly the same diagnosis, treatment, financing stuff. But you look at the model of San Jose and you realize that social support and community that's built there, it seems that it's as powerful as any medication, because social support, especially in vulnerable populations, is like, I mean, I think it makes all the difference. You want to make sure that they don't feel left out, even though society is leaving them out, and that's the cool role of safety net providers. And I think it speaks volumes that patients at San Jose don't want to leave when they turn 65. That just really struck me.
You know, I love that. I just want to say something because we're still kind of in post-Harvey, and I'll stop saying that tonight, I promise. But, you know, we're still in recovery, and that was one of the things that was really unique about San Jose Clinic is we were fortunate not to have been affected. We were able to we're small, open our doors right away, and people just came to hang out. You know, when you told them that there was going to be an hour wait on their prescription, no longer was it an issue. You know, they had a place that was dry, that was comfortable, a friendly face to see, and that does speak so much more value to their health care. I think you're right on point with that, and so that was something very unique that we had, and we were very grateful for.
Yes, go ahead.
Yeah, I want to build off of Nikki's point and just really highlight the fact that we have a very diverse population, like has come up several times. And when you explore the relationship between, so when we say diverse, we're talking about racial diversity. I think that's also important to mention. So when looking at that and the history of some racial minority groups with healthcare, it astounds me that much more that you have these patients who do want to come and hang out and do want to actively engage in their own healthcare and have agency in that. And for me, as like a person with a research brain, I'm like, I want to interview these people a little bit more and kind of flesh that out, right? Because I think the common narrative is that, oh, these groups don't want to interact, they don't care about their health, this, that, like they deserve their hypertension because they don't want to, they have chronic, you know what I'm saying? Like this is the narrative for most physicians, which is very sad, but you have success stories like this in a city like Houston, which is the number one most ethnically diverse city in the U.S., but fourth largest, right, which is my point. I mean, it can be done. And I think that needs to dominate the narrative because this is outstanding work. And it's like, okay, yes, this is happening in a lower resource setting, sure. But a lot of these things can be applied widely. And I understand Nikki raised a great point about, okay, this is especially important for marginalized populations, but I would argue that this idea of wanting to engage in your health center and your healthcare is important for those of us in this room too, because, you know, we can't change the power structures, but it's incumbent that we take care of ourselves so that we can be in the best place to provide care for these indigent populations. So it matters across the board. So anyway, that's what I want to share. Thank you.
Thank you. Yes, ma'am. Oh, there's somebody in the back there. He was, yeah.
So this discussion's taken an interesting turn, which is good because the question has been percolating in my mind. It dovetails nicely here. A lot of people are, really emphasizing a lot of the good things that you do, and many of the comments have been, well, hey, wouldn't it be great if we could scale this up? How can we? So my question is specifically to all of you on the panel, what are some things that you're doing that you think could be scaled up to the broader healthcare system? And if Mr. Nix wants to make fun of any major hospital chain in the area, I certainly invite him to do that. But seriously, you guys are doing a lot more with a lot less. So are there ways that we could scale this up to the broader areas of the U.S. healthcare system?
So earlier I mentioned this maternity bundle payment pilot that we're doing. So in the traditional fee-for-service world, right, I pay the OBGYN, I pay the anesthesiologist, I pay the hospital, I pay the pharmacy for the prenatal vitamins, This model is saying, first of all, put the mom and the baby together. I want a real, no pun intended, bundle of joy, right? So I want a real bundle, right? Because what matters is a healthy baby at the end of this pregnancy, right? So putting all that together and looking at a way to pay for all of that care as one set bundled payment. Medicaid in the United States funds a large percentage of the births in this country. In Texas, Medicaid funds about 50% of the births in Texas. And in the greater Houston area, we fund about 50% of that 50%. So 20,000 plus deliveries are financed through Community Health Choice every year. We feel like we need to be a force for good. You know, nobody else is financing that many deliveries in this community. So how do we take what we're learning from that bundled payment pilot and say, this is the way to go, incorporating both quality metrics as well as cost effectiveness metrics, and then also measuring what's really important to the patients. You know, the anesthesiologist will tell you that if the time from, you know, gas to coming out of gas is, you know, 14 minutes or less, that's a quality metric. You talk to that, you know, that woman who's just delivered, that's not what she cares about, right? She cares about being educated enough to care for that child when she gets home with that baby. So incorporating not only traditional quality metrics, but also patient-reported outcomes as well. So that's one example I can think of.
I'll give you another example, maybe. I mean, others are doing this, but integrated behavioral health, so where you have your primary care and your behavioral health specialists together as a team for one patient. We partnered with a major hospital in Baytown to do this program. And two-year pilot went very well. Now we're replicating it in our flagship in Montrose and rolling it out in other places. So the smaller FQHC, like we are, can and should, I think, work with the big dogs. Number one. Number two, I think there's also something to be done around social determinants of health. I mean, a lot of people are doing a lot of things, especially in this city. But I wonder if, you know, more of a concerted effort, a centralized effort can be made. We are starting to focus on food insecurity and prevention from these various social determinants. There's a lot of stuff there. I can't articulate it. I don't know where we're going yet as a country yet. But I know there's a lot of innovation, creativity, and like with farmers markets, we partner with Recipe for Success. Or local farmers markets in Fifth Ward. We have a stand there every once a week. I mean, and cooking classes is what I want to do for healthy cooking. But anyway, these little things, I think, and I'm sure they're being done, but they're new to us.
And we're really excited about the centering model of care, the group medical visit for our prenatal and pediatric clientele. With the Centering Health Institute, they have a lot of research and studies that show that there's increased provider satisfaction, that there's increased patient satisfaction, that there's quality outcomes are better. The productivity and the revenue that help support the FQHCs, their compliance rate for the return visits is also higher. So, you know, it's a very simple model of care that I think brings a lot of ability to be very creative about how they're delivering that. They're saying the same thing to every patient as they go room to room. Be sure you do this, this, and this. This time they get to actually have the one-on-one physical assessment, and then they gather back up in a group circle of care, and they learn from one another. And it's facilitated by the provider, co-facilitated by our staff, and it's not directed as a classroom kind of teaching. The women that are very cultural are saying, well, we did this, and so they're able to put aside some urban legends of how things should be done and really quality care for their loved ones. So I think it's a really, really nice model that I think can be easily done in other settings.
Thank you. There's somebody in the front.
Lots of hands. Very good.
Then after that, you? Okay.
Thanks. I just want to thank you for sharing like at least that perspective, and maybe have a follow-up question regarding how y'all personally feel about working in these environments. So we've mentioned that patients love it, and I don't know, based on y'all's experiences, if you've worked for more private institutions, and if you could enlighten us with how you felt different. So especially working across different, so interprofessional, right? And even within intra-professional. So what's it like, working in these different healthcare teams, and private versus these safety net programs?
For me, working with the homeless is a call. I personally come from a poor family in Upper Egypt, and thanks to a nurse volunteering in my village that I was saved, because a lot of kids at this particular time, they die with any minor infections. So I got this call and said, I will be a physician to do like this lady did to me, or to other kids like me. So I feel like we as a professional in the health area, we need to take it not as a business only, but as a call. If we take it as a call, it will change, and we can change everything. But if we take it as a business, this is a hard part. If we have this insurance that working in the health system like a business, running a business, we have to make more money next year than last year, no matter what. This is a problem in the United States health system. We need to change this mentality, and I don't know why. Universal health system would be hope and ideal for the future, but I don't know how hard we should work to get to this point, because a lot of players, they don't like that. They want to keep it this way. They want to take the large piece of cake for them, not for anybody else. So I don't know, but I hope one day we reach this point. And every time I have a nurse practitioner or a student rotating with me, I try my best to be a role model for them. I try my best to show them that for me is not really a business, is a call. I come like every morning, like I'm coming to a sacred place to serve the patient. We do in our homeless program, take care of our patient, and we wash the feet of the patient, because for us, we understood that the most important part of for the homeless person is walking, right? They walk all day long from one place to another to get lunch, to get dinner, to get clothes, to get this, to get that. So very important for them, their feet. So we wash their feet. Everybody, all the nurse practitioners, myself, other nurses, we really tell them, take your shoes off, please. We wanted to check to make sure that your feet are good. It's clean, we clip their feet, and this is very important, I think. Thank you. Thank you. Thank you.
I think it's a calling, it's my mission. You know, it's so well rewarded. I do get a paycheck, but it's not about the paycheck. It's about the quality of care that you give to the patients. And there was one, speaking of taking care of feet, there was one guy, he kept coming back to me every week. And he wanted his feet washed and taken care of. And I said, next time I'm going to charge you. I was just I was playing with him because nobody had ever. Because the first time I took off his socks, ants fell out of his socks. So nobody, and he had HIV as well. So nobody really took care of him. So, you know, he wasn't used to getting this type of attention, care, you know, and it's not his feet, we take care of everything. So it's really.
Yeah, just, I want to share another patient story that's very similar, because, you know, I can kind of sincerely feel where you guys are coming from. And fortunately, as a pharmacist, I have a lot of choices when it comes to professions, to speak to your question. In fact, I've done retail, I've done corporate, I've done academic. And the day I decided I didn't want to do retail anymore was when I had to fill a quota of prescriptions in an allotted amount of time. And I didn't get a chance to even speak to one patient. And I called my district manager. I was like, hey, I love you guys, but it's time for me to go somewhere else. And I truly love going to work every day, which is not what I can say for all my pharmacy colleagues and friends. Sometimes you have to do what you have to do because, you know, a paycheck is very important. I'm very fortunate to be in the position where I can get compensation for what I love to do. But I had a similar situation where I had a patient come. They needed refills on all their medications. And of course, my perfectly trained technician said, no, it's too soon to get your refills. You just got medications 2 weeks ago. And tears start to fall. And I'm like, what's going on? Are you okay? And he's like, well, I can't find my medication. And sure enough, I look into his profile and he has dementia. And being in a position where I could just turn around and say, hey, no problem. We can refill all of these. I don't have to submit another claim. I don't have to ask for permission. These medications are donated. It's not going to affect my bottom line. And just refill all of his medications right there, and then to see the joy, because he felt so much fear and responsibility in losing his medications, was what keeps me going to work every day. These are the kind of stories that are so touching, and this is a patient population that is so in need of places like this.
Thank you for sharing. Yes, ma'am.
Well, I'd just like you to keep telling us the stories, quite honestly. I come from an acute care model, and I'm a Methodist. So one of the big providers, but I am dealing more and more with homeless folks. I have a homeless transplant patient now. I mean, what do you do with a homeless transplant patient? Wow. You know, that's expensive medication, right? So, and we're getting more people who've made bad choices and, you know, addicted to recreational substances that just really would like our medicine. So we're doing a lot of social work. As a nurse practitioner, I'm doing more and more social work, finding out where people are coming from. And then, you know, my poor case manager social worker is just doing miracles every day. But we are getting so many more of those people. We don't actually bill for Medicaid. So those are automatically our charity patients. We are doing a lot of charity care. So, but all that to say, I'm hearing about the amazing things that you are doing. And is the Greater Houston Health Connect, is that system called ADIT? ADT?
ADT, Admission Discharge Transfer. So those are kind of the transactions that occur in a hospital that I might get notified as a payer, or you might get notified of as a provider, that your patient was admitted, discharged, or seen in the ER.
Yeah, so I'm really hoping that all the big players are a part of this organization, because I can't tell you the hoops that we go through trying to, because for me, it ends at the door. It doesn't really end at the door. I usually give them my cell phone, but, you know, like you can call me. But I would love to see there not be, you know, that there was great communication to a really good place. You know, maybe they need to be in your ACO. You know, maybe they need to, you know, go to your clinic. We send our people to Denver Harbor, which is one of our clinics. But people are shopping. People that are homeless are shopping now for, you know, hospitals and where they're going. But it'd be really great if they had somebody to take the journey with. You know, like a community coordinator. You know, make sure they get to their legacy appointment. Make sure that they, you know, and I don't know how we can communicate so that these people can get care. I don't know whether Greater Houston Health Connect is that's what the goal, the mission.
Yeah, I would say, and Nick looks like he had to leave, but essentially their mission is to create the vehicle for that information sharing. There are other organizations, and I think most of you guys also have community health workers or patient navigators that are part of your system that will help individuals find their way in the system. I mean, many of us sitting in this room have a hard enough time, keeping track or knowing where to go for, look at your insurance card, figure out where you can go for this, that, or the other care. Imagine those with low health literacy, trying to find their way through the system, and that navigation component is a significant
should we
benefit.
add literacy and those programs to a health? Teaching people to read, teaching people to apply for things, just a suggestion.
How to read a prescription label, right?
We actually tried to pilot something like that with our eligibility workers. I had this great idea that they're helping our patients do their Medicaid or CHIP renewal packets every time they're having to be renewed. And so I said, we really need to empower them and have them be able to do their own application online. Let's assist them and train them and teach them how to do this because they may not have a Barbara, the next city that they move to, that's going to sit there and handhold every step of the way. So we tried that, and I missed some stuff when we tried to pilot this program. We worked with the city of Houston. They had a classroom upstairs that had 5 computers, said y'all can use that space, no one's using it, and so we put these groups together and sent 2 of our community health workers up there and tried to teach these moms to do the applications online. And I knew teaching them that part would be, we had to do that, but I didn't think about that I had to also teach them how to use the mouse. Just the very basics, I skipped those steps, which is lesson learned, and we're going to try to figure out how we can go back and do that. But that's unfortunately difficult and a lot of time that we want to give. It's trying to find out how we can do that, though, going those basic steps of using the mouse, trying to bounce a baby on one hip from the community health worker because mom didn't have a babysitter so she could come. And so we've got graham crackers and everything all over this room. And so, but it's a need, and as we tried to empower them and help them become their own advocate of care, it's difficult, it's a challenge.
Thank you. Yes, ma'am.
Thank you. This session has been both beautiful and insightful, and I just want to thank each of you for your work, really. And I'm hearing these bundle of joy, bundle payments, and these integrative, collaborative work. And I've worked with, as an educator with at-risk, low-income children, and then also women coming out of substance abuse, and working with low-income population in West Africa. And kind of the common thread is that it's fulfilling work, but it's exhausting. And so I'm hearing, how can America scale these models? And I'm thinking America's not going to scale these models because it takes a lot of effort. It takes a lot of work and energy. And so I'm curious to know, we're kind of in a capitalist environment also, So with healthcare, I'm just getting into the healthcare administrative field, and I'm just taking note of all these different entities, and I'm seeing that there's great work happening, but I'm just seeing the challenge in actually scaling these models because it does take a lot of effort. Just like you're saying, now you have to go back and teach how to use the mouse, And who wants to spend time doing that? People do, but majority of people would rather not have to deal with it. So it is a calling, and you have to have the grace to do it in some ways. But so I'm just trying to see how we as a country will actually scale up these models.
So I think earlier we talked about value-based payment models, right? And so where we're not paying per unit of service, we're paying for an outcome. I think and the problem, I think you mentioned it earlier, is how do we get from here to there, right? We're in this fee-for-service world, and we want to go to this value-based world, and we're moving and we're moving and we're moving, but until we hit a tipping point where we're really all in with the value-based model, I think we're going to have trouble. In a value-based model, take my bundled payment. I'm going to give you this payment to deliver a healthy mom and baby at the end of this, you spend that money on whatever you feel is appropriate to deliver the results. And so if that's transportation for that mom back and forth to prenatal care, and you want to use your money to do that, you use your money to do that. I'm not back here saying, well, that's not a covered benefit. We don't pay for this, or we only pay for X number of those. So I have a lot of hope in once we get to the value-based model of payment in this country. I'm just disappointed with the slow rate of movement towards it.
To answer your question, from what I'm just thinking about, I think we also, I'll just speak for FQHCs generally, we do a terrible job of communicating and marketing ourselves, not within our communities. Like, I'm not talking about legacy at all necessarily here in Houston, but I think nationally in the power centers, if you will, the perception is somewhat wrong and not even known about what does that even mean, the community health centers. I think that is part of the problem. Just my view.
I agree with Mr. Nix because this was actually a point that has come up in our strategic plan, is to get the concept of that there is a clinic that can help you before you have to go to the emergency room, kind of through people's heads. Because health is not always a priority for our widely diverse demographic population, it is very critical that we're all kind of on the same page when it comes to educating them whenever we see them, whenever we touch them. I mean, I feel like it should be like on grocery store receipts, like here, if you need to go to the clinic. But unfortunately, to this day, people will walk into San Jose Clinic and wonder, I've never known this place existed. And we're actually 96 and a half years standing. And so for people to still say that kind of, baffles me. And so I know it is one of the major operational strategic plan items is to market our clinic better, not only to patients, but also to other clinics who may see or hospitals who may see opportunities to refer patients to San Jose Clinic.
Don't forget the ultimate goal, at least of FQHCs, is to keep people out of the emergency room. And so, and save all of that money, and that's one of the big benefits of what we do, for sure. But so, to your point, getting to the folks who walk into the ER is also what I'm talking about. So they don't go to the ER, they go to us.
Right.
Yeah, right.
I remember years back, we were looking at making sure we were calling all the clinics the same name, because they just kind of get these one-off little nicknames or something like that. And we were beginning the process of patient-centered medical home, getting ready for that. And so as we were looking at our brochures and everything, one of the managers made this face as she was reviewing it, and I said, "What's the matter?" And she said, "I just don't like that we call it a clinic." She said, in Spanish, it's clínica. That's where you go when you have to go, because you're too broke, you're too poor. You have to go there, and it's embarrassing. And from that, so from that, we now are healthcare centers. But just even making sure we are taking into account how people perceive our clinic.
That's right. Thank you so much. All right, we have about 30 seconds. Can you do that?
Yes, I can make it. Yeah, clearly I'm very passionate about this topic. Let me not blink on it. I'm curious. No, it was the pressure.
That's okay. You can email me your question and I will send it to.
That's so annoying. Follow up on what you said.
Scaling.
Oh, thank you. 10 seconds. Okay, so this is like what y'all are describing is not something that you can teach people. And I'm curious, there's different ways to go about this, right? We've mentioned some of it, and I'm curious if you guys have any other suggestions about how, I don't know, how can you teach someone compassion or just like wanting to like work for, it's just very difficult. And, from a student perspective, like, is one of the avenues going into schools and like you guys literally presenting yourselves and being like, this is another option, like this, I don't know, because this is moving, touching stories, and like to not aspire to like make all this money and do all this stuff, which is beautiful and noble for some people, but just letting it be okay and beautiful to do what y'all do too. I think just physical representation's important, so I don't know. Okay.
Thank you so much. This was a great exchange of ideas. Thank you all for coming. And let's give the panelists a big hand. Thank you.